there? The okay. So shall we start?
Sure, you can.
Okay, type. I'll start with it will be inshallah quick, and I hope that I could make a. So I was actually short of time, but inshallah it will be helpful and beneficial. So starting with this one, what's the type of congenital heart disease is most likely associated with this ECG?
Okay, this ECG showing complete heart block.
Okay.
It is commonly associated with LTGA type of congenital heart disease.
Perfect, thank you. So the choices are secondum, atrial septal defect, congenitally corrected TGA, aneuploidy anomaly, and primary atrial septal defect. Can you explain the difference between the LTGA and DTGA?
Okay, the LTGA, the aorta is anteriorly and left to the pulmonary artery. The patient can survive his life, but the DTGA, the patient he is not going to survive his life unless he underwent, unless he has a shunt, and the aorta is anterior and to the right to the pulmonary artery.
Anyone else? Yeah, the point of it is
the LTGA is actually congenitally corrected. So the RV is acting as a systemic ventricle.
Okay.
With
so the RV is pumping into the. Okay, just to make it simple, LV, the left ventricle.
The RV in the aorta. RV into the aorta. It drains.
And the RV would be its usual place, and the LV would be its usual place, or the opposite?
Yeah.
So there it will be discordant between the atrium and the valve, yes. Atrioventricular valve, and discordant between the ventricle and the great vessel.
Okay, perfect. What type of congenital heart disease is associated with this ECG? Can you read it?
Okay, showing right bundle branch block.
And?
Axis, with left axis deviation.
Which is usually common with?
ASD primum.
Okay. So the difference between ASD primum and secondum in terms of the ECG?
The secondum associated with the right axis deviation or right bundle branch block, but the primum associated with left axis deviation.
Okay. Usually the secondum doesn't need to be any right axis, but the specific is left axis deviation with right bundle branch block is for primum. Secondum, yes, can come with the right axis deviation, but it's not as it's not a must. Okay. Which syndrome is most likely to be associated with the one previously we mentioned?
The first hot or
primum comes usually with.
No, primum is Down syndrome. Yes.
Down
Sorry.
syndrome, right?
Yeah.
It's usually AV canal defect. Okay. You have a 25-year-old pregnant woman. She came to you at her 29 of gestational age. She presented with history of exertional shortness of breath, class 2, for the last 1 month. And her heart rate is 110, blood pressure is 125/75. Her transthoracic echo, you were interested in the mitral, in the M mode, and they presented you to this. What's your diagnosis?
Mitral stenosis.
So what would you do? Would you do an urgent mitral valve surgery, urgent balloon valvoplasty, urgent delivery of the baby by cesarean section, initiation of beta blocker, or initiation of anticoagulation?
Initiate beta blocker.
So how would you approach the patient with a pregnant lady with mitral stenosis?
Sorry?
How would you approach a patient with a mitral stenosis, a pregnant lady with mitral stenosis?
If the patient is symptomatic, you can start beta blocker, and if she is overloaded, you can give her diuretics to offload her. And if she is still symptomatic, then she can undergo balloon valvuloplasty.
Try medical therapy first, and if it's still class 3 to 4 symptoms, then you go for that. If she's like class 1 to 2, you can proceed with the pregnancy. Okay. So this
Yes.
one should be beta blocker. Okay. How about type? This is a 30-year-old lady, history of mechanical mitral valve prosthesis 1 years ago. She's on warfarin 4 milligram. Her INR is 2.5. She was referred by her OB-GYN to you in the clinic after she got pregnant recently. And she's now at her 10 gestational age. What will be your best action? Do you need to continue her current warfarin throughout all the pregnancy and you just DC before the delivery, initiate unfractionated heparin? Or do you switch her warfarin to enoxaparin in the first trimester, then you resume the warfarin in the second and third trimester? Or do you DC her warfarin and start the patients on the enoxaparin and resume warfarin after delivery? Or you add aspirin to warfarin in the second and third trimester?
I will choose the first answer. I will continue her on warfarin throughout her pregnancy because her warfarin dose is less than 5 milligrams. So it's okay to continue it. Okay,
perfect. So why would not be the second option?
Enoxaparin, it is not a good option if I have to give her, better to give her unfractionated heparin. But she's already in warfarin dose less than 5 milligrams.
Perfect. Okay. How about the last one, aspirin and warfarin?
Not indicated to add an aspirin. There is no risk factor suggesting that I have to add aspirin for her.
Well, usually in the literature, they provided that you can add aspirin to warfarin in the second and third trimester, but in the, as in this MCQ, the right one. But they do still add aspirin to warfarin, especially in pregnant women in her second and third trimester. So,
okay.
So pregnancy management, as you said, the warfarin is recommended for all pregnant patients with a mechanical valve to achieve therapeutic INR in the second and third trimester. Warfarin should be discontinued with the initiation of unfractionated warfarin with an IPT of 2 times the control before planned vaginal delivery in pregnant patients with a mechanical valve. You do add aspirin once daily and recommended for a patient in the second and third trimesters with either a mechanical prosthesis or bioprosthesis. The warfarin should be continued during the first trimester pregnancy. If it is, as you said, if the dose of the warfarin is less than 5 milligram, if the dose of the warfarin is less than 5 milligram, you need to achieve to achieve the therapeutic INR. Then you have either to start the patient low molecular warfarin at least twice daily with a target anti-factor 10, 0.8 to 1, 4 to 6 hours post dose or during the first trimester is reasonable. And those are just as continuous IV unfractionated heparin during the first trimester. So either one of them. So this patient, he's a 24 years old male going for a medical checkup, and the family physician asked for an ECG, and he was concerned and referred him to you. What's your opinion regarding this ECG? Medical free, he has no symptoms, and just they did for him an ECG, a part of just a medical checkup, and they found this.
Isn't it normal ECG?
Why did you say that?
Okay, I'm looking for an abnormality, but it is a sinus rhythm. The rate is about 60 or 75. There is no BR abnormality. There is no STT change of ischemia. There is there is an LVH.
Why did you say LVH?
There is early transitional zone regarding lead 3 and lead 4. There is a high R wave comparing with the other leads, precordial leads. Most probably there is septal hypertrophy.
Yeah, if you're going to say an LVH for a patient for young 24, so do you think that this is an LVH, Aslan?
No.
It can be septal hypertrophy if the patient have hypertrophic cardiomyopathy.
No. Yeah,
So it's
okay.
common.
Their concerns is okay, but to make it easier, he was concerned about the T-wave inversion in V1, V2. Would you pass it as normal, or you would say that there is something?
Sorry, I can't detect any abnormal here.
He's a family physician, but he just saw this T-wave inversion and he's kind of concerned. So we would say that this ECG is normal. The issue is the message is the T-wave inversion in V1 and V2 is usually a variant, right? But if it is more than, if it exceeds V3, then it will be pathological T-wave inversion, right? It's normal T-wave inversion. Usually one of the first causes of T-wave inversion in usually V1 and V2, if they put the lead misplacement.
Athlete male, yes.
Athletes, or actually the placement, the misplacement of the V1 and V2
Position.
was higher in the position, and then it will cause you like this T-wave inversion and like so this one will be as normal ECG. So yes, so you decided the patient has a lead displacement of V1, V2. It was 2 high leads. The primary care physicians again referred to another young male athletic who has no symptoms, and this was his ECG. Again, he was concerned about T-wave inversion, and he presented like this one. Yeah.
This one is LVH with straight better.
Okay, how would you approach this patient?
Okay, I will take a history, a family history of the patient and the patient itself, himself, and the family.
What specific questions you want to ask?
Okay, the family history of hypertrophic cardiomyopathy or sudden cardiac death at young age.
Okay.
About him, if you have any symptoms of syncope, palpitation, or sudden cardiac death, or survived arrest or something like that. Okay, then I will approach if there is a family history both of hypertrophic.
Okay, what will be your first initial differential diagnosis of ECG like this?
In this young patient, it could be hypertrophic cardiomyopathy, or if he is an athlete, it will be it can be athletic heart, or it is involved sickness due to athlete's heart.
Or T-wave inversion in the anterior leads, or
The general differential diagnosis of symmetrical T-wave inversion, it may be, as my colleague mentioned, it may be hypertrophic cardiomyopathy. It may be sign of ischemia, Willen type B. It may be a reflection of brain insult, subarachnoid hemorrhage. The other thing, it may be T memory, sign of previous pacemaker. And I think this is all.
okay. How about ARVC?
ARVC.
Be localized to the V1, 2, 3.
Yes, V1, V2, V3, and in addition to T-wave inversion, what will be there in the ARVC?
Epsilon wave in the B1, B2.
So you ask about the history and the clinical examination for this patient. You will be looking for all the signs of the hypertrophic HOCM, family history, especially about asking 3 generations of any history of cardiomyopathy, history of exercise, and how, if they had any history of syncope before. And then you will ask, the second thing you will ask for echo to assess him for his LV function. So this one, this one. Now, I have seen this and I told you that it, can you recognize anything or you would pass it like?
There is dilated RV, I think. The clip is not that clear, but I think there is a dilatation of the right side of the heart.
Okay, actually, no, it's just maybe the picture is what like.
Mitral valve. Okay.
If I told you at this stage that this echo is not that very easy, what do we do next?
TOE.
We can't hear you, Dr. Magdi.
If I told you that the echo was not conclusive, it was like they passed as normal, and there was nothing that they could recognize. So what would you do next?
I will do a CMR, cardiac MR for this patient.
Serial cardiac echo, or what?
She mentioned CMR.
CMR.
About TOE.
Again?
TOE, transesophageal echo. Or CMR, cardiac MRI.
Right. So, cardiac MRI is one of the class 1 indication. If the echo is inconclusive, you need to ask for it.
Yes.
Yes.
The first one is showing what? This one?
There's a septal, asymmetrical septal hypertrophy.
Okay. Type. Like the various form. This is a. What is this one?
An apical type of HCM.
Which is called what?
Yamaguchi Japanese type.
Yeah, Yamaguchi.
Like representing 25% of the HOCM. The 75% is like septal, right?
Yeah.
So CMR is indicated when echo is not conclusive. It's level 1. It's class 1. And the importance of the MRI here is that 10 to 15% of HOCM actually demonstrate a focal hypertrophy, only one segment. So regions of the LV hypertrophy that can be seen by the CMR, that poorly seen in the echo, is like the apical hypertrophy, the posterior interventricular septum, and the basal anterolateral. So this M mode is showing.
HOCM, there is an
Mitral valve prolapse.
HOCM, why did you say HOCM?
No. Mitral valve prolapse.
Okay. So you can see it here, right?
Yes.
Prolapse, yeah. Type. This is another example of the mitral valve. They can bring it with a note as well. If it is with a color, it will be in this part. The mem, if it is not holosystolic, it's the late systole actually.
Yes.
Right. 50 years old male who presented with a history of chest pain for the last 18 hours. By the time he presented to the hospital, his vitals were as follows: blood pressure was 90/50, heart rate was 110. The ECG showed an anterior STEMI. He was taken to the cath lab and it showed that he had approximately LAD of 100%, OIM of 60%, RCA of 80%, ejection fraction was 35, with a multiple regional wall motion abnormalities. What would you do now? Would you do a PCI to the LAD followed by PCI to RCA? PCI to followed by FFR to RCA and OM, and PCI if hemodynamically significant. PCI to the LAD and observe, or urgent cabbage?
Urgent cabbage. For urgent cabbage.
Any other thoughts? We have a anterior. What is the culprit?
I couldn't hear you.
Anterior is the culprit.
the culprit after the LID.
And the patient is having,
Proximal LAD 100% occluded.
but clinically he's having what?
Anterior
Hypotension.
STEMI.
He's in cardiogenic shock, right?
In cardiogenic shock, yes.
Usually in patients with STEMI and cardiogenic shock, you do the PCR, the culprit lesions only if indicated, okay?
Okay.
Right, how about this one? This is a 58 years old male with known case of non-ischemic cardiomyopathy for the last 2 years.
Excuse me, Dr. Magdi. In shock trial, in STEMI patient, we have to revascularize the only culprit artery just, or all the vessels.
Yeah, the culprit, if the patient is stable, it was usually, initially it was class 3, right?
Yes.
It is a class like class, I believe 2B or 2A, is that still you can do the non-culprit if the patient is stable, okay?
Yes.
Not like before. Before it was only the culprit you do it, but now they can't do the non-culprit. If the patient is stable, then you can go for both, okay? Not like before that restaging. But this one is 58 years old male who's known case of non-ischemic cardiomyopathy for the last 2 years. Presented with a class 3 shortness of breath. He's already on direct medical therapy, including maximum dose of ARNI, aldosterone antagonist, beta blocker, and diuretics. An examination, she appears to be euvolemic. Her blood pressure is 110/80. Her heart rate is 70. She had a normal JVP and clear lungs. Her echo is 30% and showing moderate MR. Creatinine clearance is 50. Hemoglobin is 11. Ferritin is 80. And she has a potassium of 4.8. What can improve her functional status and quality of life? Would you add an ivabradine, ACE inhibitor, erythropoietin stimulating agents, IV iron?
IV ion.
IV ion.
Okay. Why not ivabradine?
Plus 2.
Not more than 70 to add everybody.
Why not ACE?
Because already patient on the ARNI.
So the message here is that in a patient with a class 2 and 3 heart failure, iron deficiency, especially if ferritin is less than 100, or it is between 100 and 300 nanogram, and the transferrin saturation is less than 20%, IV iron might be reasonable to improve the functional status of quality. And in a patient with heart failure and anemia, erythropoietin should not be used. Actually, it increases the risk of thrombosis, so it is class 3. Okay.
Yes.
So you have this 45 years old female, history of mitral valve disease. She presented with infective endocarditis with a staph aureus in the blood. They did for her transthoracic echo. It showed a large vegetation on the aortic valve. Her TE showed a large abscess as well, the moderate AR. Clinically, the patient was in heart failure. They started her on diuretics and she's stable. She developed TIA, and her MRI showed a severe lacunar infarct with no hemorrhagic transformation. What would you do at this time? Do you need to complete 6 weeks of antibiotics and then operate on her once her MRI?
No.
Proceed for surgery.
Proceed for urgent surgery.
To the urgent surgery, or you repeat an MRI and conservative measure. So the message.
She had all the indications for urgent surgery.
Not be delayed following a stroke if there is no emergency. Okay. So, which subgroup of patients are a candidate for? With class 2, shortness of breath, non-ischemic cardiomyopathy 30% 1 month ago. 52-year-old man with a class 2 heart failure and a non-ischemic cardiomyopathy with a lemon AC missense, mutations, ejection fraction of 38%, or 33-year-old man with hypertrophic cardiomyopathy and LVO gradient of 100, asymptomatic, or 78-year-old woman with a new onset of class 4 heart failure and new diagnosis of non-ischemic cardiomyopathy and ejection fraction of 20.
B.
No, the B is ejection fraction of more than 35%. Yeah, Sarah.
صح. But all the other
C.
indication.
Hypertrophic cardiomyopathy, resting gradient is 100.
What are the criteria for ICD implantation?
In HCM patient, in HOCM patient, Dr. Magdi, or in general?
In HOCM, what are the
In HOCM patient survive cardiac arrest, or the patient with family history of sudden cardiac death, the sickness more than 30, if there is an aneurysm, LV aneurysm, lead godaline in heart cell more than 15%, and non-sustained VTAC and unexplained syncope.
So did they brought anything about the gradient? No, right?
No.
Yeah. Asymptomatic.
The gradient is not part of it, right?
No.
So, the first one is?
طيب نختار.
How about the first one?
First one, diagnosis ischemic but 1 month ago. يعني المفروض in at least 3 months of optimized medical therapy, I think.
Yes.
Okay. How about?
At least 3 months.
Okay. How about D?
D in class 4. Class 4, is it an indication? I don't. يعني ما أعرف.
A new diagnosis of non-ischemic, also new diagnosis.
He is in class 4 heart failure.
Actually, B.
And he's in class 4. B is the most by exclusion.
But yeah, it's actually the percentage is 45. Okay, and you said, I think you said 40, but they said in a patient with non-ischemic cardiomyopathy due to lamin AC mutation who have a 2 or more risk factor, non-sustained VT, or ejection fraction less than 45%. Non-ICD can be beneficial if the meaningful survival is greater than 1 year. Okay, so that's really B.
That means in ejection fraction in this particular case of lamin A and C deficient mutation, yes? Not in general cases of non-ischemic cardiomyopathy.
Specifically,
Just reduce ejection fraction. Am I right?
No. In non-ischemic cardiomyopathy, mainly due to lamin A and C mutation, we take ejection fraction less than 40%.
yeah. So laminopathies generally is a disease caused by mutation, mainly lamin AC gene, that produce a various inherited disease, including subtypes of muscular dystrophy and Brugre. Isolated cardiac involvement is also observed and is an important cause of familial cardiomyopathy. It is highly penetrant, such as all affected individuals have evidence of disease by age. All the manifestation may include inflammation, so a number of observational studies reported that they are at a risk of sudden cardiac death. So that's why the ICD is a candidate here in this specific group. Okay. I think I'm done with that. So it's a very short.
Nice. Thank you.
Thank you so much.
Thank you so much. Really, it was very enjoyable.
Thank you so much.
Thank you.
Thank you so much, Magdi. It's a nice and short and great.
Yeah.
So I think we're gonna do tomorrow maybe again. I'm gonna post you the exact time on the topic in the group.
Okay.
Thank you,
Okay.
Dr.
Waiting
Hatem.
for that. Thank you, Dr. Hatem.
Thank you so much.
شكرا لك.